But the purpose of this video is to distinguish the buprenorphine and naloxone combination drugs, i.e. Suboxone or their equivalents, to distinguish them from methadone. Hello and welcome to this edition of the Wise Medical Minute. We are often asked, what is your specialty? And we don't have a simple answer for that question, but I've created a moniker, Personal Image Enhancing Services, to describe all the activities that we do. So my subject today might seem a little disparate because we're more well known for things like liposuction, Botox, and fillers, and helping people lose weight and fixing their hormones. But it has come to my attention that few things improve an individual's appearance more than getting them off drugs. So we are pretty passionate about our opiate dependency treatment program. And one of the things that frequently comes up in that context is a confusion between Suboxone and methadone. Now let's define opiates first, and then I'll get back to the main point of the talk. Opiates are those drugs that are opium-derived or synthetic products that act the same way. We don't need a whole pharmacology lecture on that subject, but to make it clear, we're talking about heroin, we're talking about oxycodone, we're talking about morphine, we're talking about kratom, we're talking about tramadol. Lots of things that people think are relatively innocuous. They're all opiates. They all kill you the same way. And they all have a very similar withdrawal symptom or complex that is what really makes them difficult to deal with. And folks who want to cast aspersions about drug addicts need to understand that by the time people are addicted to opiates, they take opiates to keep from getting sick. It's not fun anymore. Okay? Yes, it starts out from simple recreational abuse sometimes. Too often it starts from iatrogenic, i.e. doctor-caused use of opiates when overprescribed for simple things that could be managed with less aggressive pain therapy. But once people are addicted to opiates, they need a way to get off the opiates. That leads into talking about Suboxone. Now, Suboxone is the popular name for the most common drug or the most common form of buprenorphine combined with naloxone. Now, I don't have any stock in the company that makes buprenorphine, any of the buprenorphine products, so I'm comfortable mentioning all of them. Bunavail is another brand of the combination of buprenorphine and naloxone. And we have lots of brands of pure buprenorphine that have different uses that we can talk about in another video another day. But the purpose of this video is to distinguish the buprenorphine and naloxone combination drugs, i.e. Suboxone or their equivalents, to distinguish them from methadone. Now, methadone was originally designed as a pain medication, as a very useful pain medication for people who need to be on pain medication for a long period of time. But it has been approved and found very useful in treating people who were addicted to other opiates. The track record for keeping people out of relapse is good for methadone and thus its popularity. Problem is, it is as much of an addictive drug as the drugs that they're using it to treat. Now, the success rate for getting off of methadone is the real challenge, and I think we need to make it clear that coming off of Suboxone or other buprenorphine products is a lot easier than coming off of methadone. In fact, we use Suboxone to treat methadone dependency. So the reputation that Suboxone has acquired appropriately as being the witch for the devil is deserved more because of the dosage forms available. And if they were to make lower dosage forms available and make it easier to taper off the drug, we wouldn't have this terrible reputation that if you get on this stuff, you can't get off. Now, people can and do get on and off Suboxone, okay? So as I mentioned, there's two different drugs in one. Buprenorphine is the active ingredient. The second ingredient, naloxone, is there to deter abuse. It does nothing but make your poop expensive if you take the drug as directed. But if you try to grind it up and shoot it up or snort it or do all the things that addicts do with other opiates, it will precipitate withdrawal. And it's there, A, to deter abuse, but B, you can't overdose on this stuff and nobody's gonna die. So that's the reason the naloxone is present. It has no active role as far as treatment. Now, there is no deterrent combined with methadone, so we have to understand that that's why people can go on and off heroin or on and off the other pain meds when they're taking methadone. On the other hand, there is a risk of something called precipitated withdrawal if you combine those other opiates with Suboxone. It's not pretty when you see it, but there's a drug interaction that results in withdrawal from the previous opiate when you take Suboxone before you get the other opiates out of your system. Another talk for another day, we'll talk about the induction process. But the main virtue I want to emphasize for this particular conversation is that people's cognitive functions are not as compromised on Suboxone as they are on methadone. Therefore, this is a very effective way to maintain people long-term or to treat people short-term as a way to get off drugs. Suboxone does not cause the patient to experience the high that you get from methadone or some of the other opiates. And after stabilization, which is in days, not months necessarily, but days to weeks for sure, people can return to work as normal and remain on Suboxone. I'm not as comfortable, even though a lot of people do it, telling people that they can work normally on methadone, although people do it every day. So it's a lot safer as far as things like operating heavy equipment, driving, anything where you have to think about what you're doing, crunching numbers. Any kind of cognitive function is going to be less impaired when you're on Suboxone as compared to methadone. Now, you have to also understand that if we use this as a tool to detoxify, meaning we give someone something to keep them out of withdrawal while they're getting off of whatever they were previously addicted to, very useful tool. The other concern, though, is when it's time to come off the Suboxone. Now, we have to understand that buprenorphine is a very potent drug, and we're familiar in the lay press and general medical settings with the potency of things like fentanyl. You hear about fentanyl all the time. Fentanyl is dosed in micrograms. They dose Suboxone, to my chagrin, in milligrams. So if we were to be more reasonable about the dosing, I believe buprenorphine should be dosed in micrograms. Now, to put that in focus, when treating pain in patients who are opiate naive, meaning folks who don't take pain medicine every day, the dosage forms for buprenorphine and other products ranges in the neighborhood of 75 to 80 micrograms per dose, okay? And doses as low as 25 or 50 micrograms have been used in some circles. Now, the problem is when you're treating opiate dependency, the dosage forms available, the lowest dose is 2 milligrams. That's 2,000 micrograms. So it's no mystery why it's difficult to come from 2 milligrams to 0. And the other thing that I have to stress is the package insert is just ludicrous. They seem to indicate that everybody needs to be on 16 milligrams a day of Suboxone. My argument is, unless you're treating legitimate chronic pain, nobody needs to be on 16 milligrams of Suboxone a day, unless they're really coming off extremely high doses of heroin or extremely high doses of oxycodone, or, more often than not, when someone's taking that much, they're selling it, or they're sharing it with somebody, or they're doing something illicit. There's divergence all over the place. The bottom line is nobody needs that much Suboxone. So if you can treat pain with something less than 75 micrograms, why do you need 8,000 or 16,000 micrograms to treat opiate dependency? That just puts it in focus. Okay, now the other thing, when it's time to taper off of Suboxone, we have to understand 3 basic principles. One is the brain is plastic. And what do I mean by that? The brain can be programmed. It's malleable. It can be changed. It goes both ways. It'll get used to as much stuff as you give it, or it can adapt to as little as you provide. So adjusting the amount that you're exposed to by gradually reducing it over time allows the brain to adapt. Now, years ago, we did develop our own little tapering protocol that I originally developed with pregnant patients. And we've since expanded its use to everybody. And the bottom line is, with compounded buprenorphine, such that we can make the dose adjustments in smaller increments or decrements, we can use a compounded product in a stable and gradual sort of way to get almost anybody off buprenorphine without having to experience withdrawal. I'll talk more about our tapering protocol in a future video, but the bottom line is, by virtue of this drug being a long-acting drug, that's part of how we're able to taper people off. And that's the second point. And the third point is, we have to remember that the brain thinks in percentages and not milligrams. So going from 2 milligrams to 1 milligram is a 50% reduction in dose that feels the same to the brain as going from 16 to 8. Obviously 16 to 12 or 16 to 14 is better tolerated, and I won't bore you with the details of the Locke method for tapering people off buprenorphine right now, but you can get a little more information by inquiring at info@wisemedicalcenter.com, and I'll share with you as much information as you desire. But the bottom line is, people are more functional, people can work, people can drive, people are alert enough to do anything they would normally be able to do while they're taking Suboxone. I can't say that about methadone. And methadone's a full agonist. It is going to make you high. It's going to require a little more difficulty coming off of it than the buprenorphine-containing products. But please don't confuse Suboxone with methadone. Last but not least, there's experience being accumulated with other forms of buprenorphine besides the traditional tablets or strips that Suboxone comes in. There's a once-a-month injection that, like so many drugs in the United States, is too expensive for us to have much experience with. But Sublocade is a brand of a drug that can be used with a single monthly injection, which I think should be more prevalent in our daily use than it is, but again, because of cost, it isn't. My practice, the real reason is I don't want to fight with the stupid insurance companies to get it paid for, so I take the blame for having less experience than I should have. But basically, we need to, when cost is not a factor, get more experience with this once-a-month injection form of buprenorphine. Lastly, Probufene. I was the first person certified in the state of Georgia to do the Probufene implant, and my experience is nil. But that's because, again, costs. It makes no sense for 6 months worth of medicine to cost $5,000. But that's what it costs. And because of that, the experience is limited. But I believe that once this drug becomes properly priced and more available, it will provide us with yet another mechanism for tapering people off without having to experience withdrawal. And the whole concept of taking a pill every day, or taking a pill or a shot or something under your tongue every day, we can circumvent that with the monthly or the every 6 month methods of administering the drug. But we're waiting for the drug companies to get more reasonable with their pricing, and I look forward to talking about these products more in the future. So thank you for your attention, and as always, I appreciate you making the wise choice.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approached from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.